It is that time, you all, my Be Health Empowered family. Welcome back to another episode of Excuse Me, Doctor. My name is Dr. Mel, also known as Dr. Melissa Clark. I am delighted to be back here with you this week. We're here every week, every Monday, doing what we do at Excuse Me, Doctor, which is giving you the information that you need and the insights to help you make wise health decisions, not just for yourself, but also for your family as well as your community. So, thanks for tuning in on any of our multiple platforms. If this is your first time, please go ahead and hit that like button if you're on Facebook and that subscribe button if you're on YouTube. We really appreciate you for it. And of course, we are here for you. So please put those questions and concerns, comments in the chat. We'd love to hear from you. So, with all of that out of the way, let us get into making an amazing week for ourselves with everything we're going to talk about tonight. To do that, I have to have Mr. Wayne Bruce at my side, bringing the word on the street to us.
I'm in these streets, Dr. Mel. Well, actually, I got the streets above me and the water behind me. So I'm in these streets tonight, Dr. Mel.
I see.
The word from the street.
From the street and from the waterways. So that's
the waterways, more important than the streets. Somebody throw me a rap or a lifeline because I don't swim well. We need to do a show on that. That's what we need to do. A show.
We do. But tonight, this is a special episode because we have once again our collaboration with Howard University's Research Centers and Minority Institutions, their Community Engagement Corps, and representing them, we have none other than the wonderful Miss Karen Parker.
And there she is.
Good evening, family. Good evening. We're all wearing shades of purple again, I see.
Yes,
we got a sartorial memo.
Somewhat. But so thank you again for joining us for this second episode of our collaboration with Howard University. So, Karen, tell us a little bit again about RCMI and what you do.
Thank you for having me again. I'm glad to be welcomed back. We at the Research Centers for Minority Institutions, which is what RCMI stands for, it's a program that is funded by the NIMHD, which is the National Institute for Minority Health and Health Disparities. And the goal of that program is to enhance and develop the necessary research infrastructure that ensures our ability to contribute to the resolution of these diseases that disproportionately affect the communities that we serve. So basically historically disadvantaged populations. Now, my group is the CEC, or the Community Engagement Corps. And what we do there is to make sure that the research that we do at Howard speaks directly to the communities and what they need and what they're most interested in. So that's a little spiel about my role. Again,
all right, cool. So they're making sure that HBCUs like Howard have everything that they need to serve the community when it comes to research and making sure that everybody has the best quality health.
Exactly.
Yes.
Absolutely.
And the community.
And to that end,
in the community, we applaud you for that. I mean,
yes,
because
absolutely.
I'm in these streets and these waterways. I hear it all.
Yeah, I do.
Yes, he's hearing the applause even as we speak. And so that brings us to what we're talking about tonight. So we had our first ever kickoff episode. We talked about Alzheimer's last month, joined by a fantastic panel. And you all out in Be Health Empowered land had such an incredible response to it. We said, wow, we have to have a follow-up episode so that we could talk about all the things that we didn't get to cover, right?
Right.
So here we are tonight. We're talking again about Alzheimer's disease, but tonight we're talking about treatments and we're talking about how to navigate the healthcare system and get the resources that you need if your loved one has Alzheimer's disease, do that for that person as well as for yourself and your family, so that you have the support that you need to help take care of them. So that's it for tonight, y'all. That's what we're talking about.
And they
And
already, that people are in the chat saying they're excited about tonight's discussion. So let's get it on.
all right, all right. Well, first up on our panel tonight, we are welcoming back Dr. Neelam Agarwal, who joined us the first time, but she was so incredible, you all demanded that she come back, and she is here tonight. She is a professor in the Department of Neurological Science in the Alzheimer's Disease Center at Rush University in Chicago. She's also the Chief Diversity and Inclusion Officer of the American Medical Women's Association. I think I got that right. Thanks so much for being here, Dr. Agarwal. And I think you're on mute, but I think you said thank you for that. You're glad to be here.
I'm so excited to talk about
All
this
right.
topic with you all tonight.
Wonderful. Well, let's get right into it. So last time, I think what bowled people away was the analogy that you gave of dementia being a book and Alzheimer's disease being a chapter in that book. So I would love if you could kick us off by explaining what's written in the pages of the chapter on Alzheimer's. So, in other words, what is happening in Alzheimer's disease that's leading to memory loss? What's actually going on in the person's brain?
Okay. So the first thing, just a little recap for everybody. Alzheimer's is a type of dementia, and there are many different types of dementia. So I think, Dr. Mel, just to answer one of your questions, how can you be prepared to have a discussion? Whenever you hear the term dementia is being used with a loved one, a family member, or friend, in your mind, you should be saying, okay, here's some changes in thinking that involve memory, language, judgment, but what kind of dementia? What type of dementia is occurring? Okay. And that's, once we get that down, I think people are going to understand the different types of dementias as I go through them. Now, the Alzheimer's dementia type really is characterized by short-term memory loss, then followed by trouble with speech, trouble doing things you used to be able to do, judgment, calculations, balancing checkbooks, making change. And in the brain, what we feel is happening, there's a lot of things happening in the brain. So that's the first thing that's occurring. Many of these changes, Dr. Mel, are occurring, right, what we know now, even 20 years before it even shows up outwardly. So things are happening in the body that we don't see yet. It's almost like an iceberg, right? You see the tip coming up, but underneath that water, there's this whole iceberg. So things are happening. And we see amyloid plaques and tangles. Those are the two key things that, again, your listeners need to remember. These are the two things that we see in the brain. And the level or the amount of the amyloid plaque or tangle is what sets the diagnosis for Alzheimer's disease. So we all have it. It's the amount that matters, okay? And it gets really important now as we're going to talk later about treatments, why that matters. So it's amyloid plaques and tangles. And then the other thing that happens is the cells begin to die around the amyloid plaques and tangles. So you start to see changes with the size of the brain gets smaller, and the connections between the cells start to die. So those little connections aren't as dense as they used to be. And that's what we think shows up later if anyone's talked to someone who's had dementia, you can almost see, especially Alzheimer's, you can see them thinking real hard. And it's just not coming. It's just not coming. Right.
And when you say amyloid plaques and tangles, I want everybody to think of these are protein. They're proteins.
They're proteins.
But think of them as trash, like trash that's building up in the brain that's not being disposed of as quickly as it should be.
Exactly.
So we talked about treatments. We covered a lot in the last episode. So we're going to just jump right into treatments. And I'm glad that you kind of set the table like that, because to understand how the treatments work, you kind of have to understand what's happening. So this past week, the FDA, Food and Drug Administration, approved a new treatment for Alzheimer's disease. It was all in the headlines. And
Yeah.
it's said to be the first that's going to slow the progression of the disease, the buildup of this protein, these
Yeah.
amyloid plaques and tangles. Can you tell us, is that true? Do you think it
Mhm.
works? And what should people know about it?
Yeah, it was a lot of news definitely last week. It's continuing into this week, and I can tell again, our viewers and listeners, it's going to continue for the whole month. There's a very large meeting occurring at the end of the month on Alzheimer's disease, and this is going to probably dominate quite a bit of the discussion. So to
Mhm.
answer your question, Dr. Mel, yes, this new drug, lecanemab, that we know of this drug, not only clears the amyloid in the brain, we have pictures to show it in live brains. This is important, not people that have died, but particularly live brains.
Mhm.
And it also has been shown to increase or at least to help with the thinking process. So the decline in thinking that we see with Alzheimer's was lessened in people who took the drug. So the key point here for us in the field was that both things occurred. We've
Mhm.
had problems with our studies where we may have a drug clearing amyloid, but nothing changed with the actual memory tests or thinking. And that put us in a situation where, okay, we're seeing one thing occurring, but clinically we're not seeing it. And that's why some
Yeah.
doctors we're not excited about it. This is the one where both occurred. And that's where I
Mhm.
think a lot of that excitement has really come from that.
Yeah. So what does that mean for other prior treatments
Yeah,
that
yeah,
sort of have been the standard in the past for what
yeah.
individuals with Alzheimer's disease have been started on?
That is such a good question, Dr. Mel, because you know this as much as I have. We've been prescribing medications. You're in the ED, you see people coming in on the other medicines like Aricept. Again, our
Mhm.
audience will know these drugs most likely. Aricept, galantamine, Exelon. There is still a place for those drugs. But, the method of action of this new drug is very different than the earlier drugs. And I want everyone to keep that in mind. It's a different way of attacking a problem.
Mhm.
And some people, frankly, will not be able to tolerate this new medication. And it may not be safe for some people to take this new medication. And therefore, that means those drugs are definitely still much in play. The other
Mhm.
thing is people who are on those drugs, okay, they may not have to come off those drugs to get this new drug. And that's a big issue for some families. Like, I'm not going to take my mother off that drug to get this
Right.
drug, right?
Yeah.
So, there is definitely a place for those drugs. This is a different mode of action. It's much more invasive than the pills or patches that we've been using.
Yeah.
May I? I actually have a question, a follow-up to what Dr. Mel was asking about, because you introduced the topic of the new drugs, and I was about to ask about the old drugs. Where are we in the research stage? Are they testing combinations of what's already been approved against this new one or
Mhm.
alongside with the new one to see what the regimen may need to be in future?
Yeah, no, it's a great question, Karen. Yes, 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 in the sense of we're doing clinical trials right now. So I want everyone to think about the trials that are ongoing right now in the country, here in the US, Canada, Europe, Asia. And we have people in those trials on those medications that now are going to say possibly, I want to come on lecanemab too. So they're going to be on both drugs, okay?
Mhm.
Or they're going to say that, if I'm worsening in a trial and I'm on a medication for, for Alzheimer's, I still want to be put on the new drug. So these kinds of things, these combination therapies are very much in our discussions now.
Mhm.
We're thinking about them very clearly about how we should approach these combo therapies. And frankly, if you're going to do both, when do you introduce them? What do you introduce first? And then when do you do an add on? Okay. And I'm looking towards our colleagues in cancer, our colleagues in cardiology that have done multiple drugs being utilized to handle a problem. How do you handle it, right? We have been doing things, if you think about it, monotherapy.
Right.
And that's not
So
how
one drug at a time. Yeah.
absolutely, right? In
Yeah.
medicine, we don't work like that.
Yeah.
And we don't. So this is new for us in the field.
Mhm. So, it also begs the question of, we hear some drugs being better for mild Alzheimer's disease,
Mhm.
moderate Alzheimer's disease, but maybe not so great for late stage disease.
Mm.
Can you just give us a sense of what that progression is? What does it look like? And
Yeah.
how do we know if our loved one has mild, moderate, or late stage disease?
Yeah, that's another great question, Dr. Mello. So when it comes to mild, moderate, or late stage, a lot of times those distinctions are made by the physician or the clinician. And it's a good question, again, for your viewers and listeners to ask, what stage is mom in? What stage is dad in? Or my husband? And we use the word staging to really help us understand, what would be the impact if we started a drug or not. So let's talk about, mild disease. Mild disease is, in clinically, it's when people start to complain or you hear that they're having much more difficulty communicating, remembering things. And it's starting, a lot of times they know, patients will know something's not quite right. Something's not quite right. And sometimes family members can pick it up, sometimes they don't. It gets picked up at work. And in those stages, in the past, we would monitor people because we didn't have any good indication to start people on a drug because maybe on their testing, they were doing pretty good. Now, with these new drugs, we're now going to look at the amyloid level in their brains. And based on the level, we're going to be able to say that level is too high and that level is concerning. And now we're going to start the medication. So this is really like the precision medicine of this type of thing. Now, moderate stages is when more people notice. And here you get much more, it's pretty noticeable. People sometimes lose their jobs they're losing. They're now needing more help. The family is stepping in a lot more now to do bills, to do grocery, to pay the car note. They're doing things more in moderate stages. And we also start to see more behavior changes, okay? The moodiness, the aggression, the agitation, sometimes the hallucinations. Now, in that stage, a lot of times certain drugs may not be indicated because it may be already too much in our mind of the potentially the plaque buildup or the pathology. And we may opt for different meds, the oral meds and the behavior meds to really calm down the behaviors. Mm-hmm.
Okay. And then late stage, I would imagine, is
Supportive. It really
when
is, Mel.
people really can't do anything for themselves.
Yeah,
Kind of
Mel,
total care. Yeah.
this is a tough one. And I understand people, I've had people say to me, we got to do something. I just can't give up. And they, a lot of times families feel that I'm giving up on mom or dad. I'm giving up on my husband. It's very, very, it's a tough stage because is there anything else I can do? I can tell you late stage is more for comfort and making sure if there are mood issues, really trying to treat the mood issues. So the quality of life is as best as we can get that. Some of the medicines that we're looking at and talking about tonight aren't really appropriate for the late stage person.
Great. So I think we're going to take a quick break and check in with Wayne to see if there are any questions in the audience. Wayne, anything you're seeing?
Let's do that first. Yeah, we do have a question. Our question comes from Marv West. And Marv states, please state what the new drug is and how it can be acquired.
Okay. So the new drug, Marv, is lecanemab. That is the trade name lecanemab. This is it's a MAB. It's a monoclonal antibody, okay? And this drug, like an antibody, what antibodies do is they attack things and kill things in the body. And they're very specific antibodies in general. This one is specific to that amyloid we talked about in the beginning of this segment. So the monoclonal antibody will find the amyloid in the brain and attach to it and remove it and get rid of it. And that is the mechanism of action, okay? Now, the second part of the question, if I remember right, is where do you get this or how do you get this? That's where we're going to have these discussions. And again, I want to just tell your viewers and listeners, this is a process. This is not going to be a very, very fast thing. I suspect there's going to be variation across the country, okay, of where you live and where you are and who's going to get things done faster. It has to go through not only insurance coverage, but it has to go through health systems. One of the places I would say to look at is any kind of an academic center that does work in the area. Find out what their timeline is going to be, okay? And how you acquire it is the FDA and even with CMS, they would like people to enroll in a registry, okay? So you're enrolling in a program, and within that program, you're going to be evaluated if you qualify for this drug. And based on that qualification, then the drug would be given to you. And that is a process that will take time.
And I'm really glad that you brought that question up, Marv, because that helps us segue to our next section of the show, where we're going to be talking about how to navigate to get the best possible care. So knowing to ask for that medicine is one of the ways that you would know how to get the best possible care. You might have to ask for it before you're considered for it. And so, Karen, can you go ahead and introduce our next guest?
Absolutely.
And we'll be back to Dr. Agarwal. So
I'm so excited to do this because she is a Bison family member. Please welcome Linda Irizarry. She is a licensed graduate social worker, trained at Howard University. And she has had over a decade of experience working with the elderly and adults with disabilities, as well as training family caregivers. She not only had the professional experience, but she was also a caregiver with her own family. So good evening, Linda, and welcome.
Okay. Can you all hear me?
We can hear you.
Yeah,
absolutely. Welcome.
Hi,
Welcome.
Good evening. Good evening. Thank you for having me.
Absolutely. I think I'd like to get started with this decade of experience that we just talked about. You were with the DC Department of Aging, was it? Aging and Community Living. Could you tell us a little bit about the role that you played there?
Sure. So amongst that 10 years, I had an internship for about a year working with nonprofits that the Department of Aging funded, and then about nine years and 4 months with the Department of Aging and Community Living. And during that time, I ran a caregiver support group, and I ran 2 federal grants. One of the grants was entitled Lifespan Respite. So that helped connect caregivers to respite care services so that they could get a break from caregiving. And also under that program, while connecting the caregivers to not only respite, I did a comprehensive assessment to see what other services and supports that they would need while assessing them for respite. And then also I had the great opportunity to manage our Alzheimer's disease and related dementia grant that we had from Health and Human Services. And under that grant, we had the Savvy Caregiver Program. So that was a evidence-based 6-week training that we provided education to family caregivers and caregivers in general. So that was really great. And then also, yes, it was amazing. I met so many caregivers and got to connect with them on so many levels. And then also we had a pilot for our arts poetry program, where they use different forms of art and poetry to connect with those with Alzheimer's and dementia. And then also the last thing on that program was we were trying to, as our social workers in the field, we're assessing the elderly. We also had like an early detection component that we had added into that grant as well. So that was some of my work at the Department of Aging and Community Living. And then I also manage grants for adult day health, which is a really good resource for family caregivers to get their loved ones with Alzheimer's and dementia connected to, if that's the appropriate setting for them.
And that sounds like a very comprehensive role. So thank you for all that you did in that role, certainly. And this was in Washington, D.C. Could you tell us a little bit about the kind of care that people need who have Alzheimer's, dementia, and the stages of disease that Dr. Agarwal was referring to?
So it really, Dr. Agarwal, as she was going through the diseases, it really depends on the person's level of care, what they can do independently with assistance. So that's once you kind of get that assessed, and we'll later discuss like elder care and how to get connected to those services. Once you have been able to determine the level of care, you kind of know what kind of services and supports that you would need, and also the relationship that they have with the family caregiver and the environment. All of that kind of, it's like a holistic picture when you are really determining the services and cares for that person with Alzheimer's and dementia.
So you basically would need to have a very close dialogue with the providers, right? There has to be sort of a very close conversation thread, as it were, between the caregivers, the providers, and social workers in that space. So it sounds like that kind of care can be very expensive. So can you talk about what that looks like, what that might look like?
Sure. So it really just depends on the person, their insurance, what type of insurance types they have. It also depends on the government services of where they live, because every area in aging offers different services for their area. For older adults and their family caregivers. And then it also depends on like private pay, also what you and your family can pay out of pocket. And then, like I going back to other service and support and really leveraging what is around you.
And so is it, so I'm sorry to jump in. So in other words, there's some costs you're going to have to cover out of pocket, right? You could potentially have long-term care insurance, which might help to cover some of the costs. But what about Medicaid, for example? I know that's, for those who don't know, that's some insurance for people that have a certain percentage of the poverty line, right? So lower income individuals, if they have Medicaid, what kinds of assistance might they also get?
Sure, that's a great question. And then I'll also discuss another like government resource that some people may be able to tap into. So depending on their Medicaid program in that state, so each state has their own state plan assessment or program in which they run. So some will include respite in there, in-home support, modifications to the house, because, as Dr. Agarwal kind of mentioned, as you go through the various stages, your physical ability and other things like that may decline, so you may need home modifications. So those are some of the services, and OT, PT, depending if the doctor orders that. Those are some
occupational therapy or physical therapy.
I'm sorry, yes, occupational therapy, physical therapy. I've even seen in some slight instances, depending on the person's stage, that they were also able to get connected to speech therapy because of just how the disease progressed with them. And another government resource is if the person was a veteran, there's aid and attendance that they can get through the Veterans Administration. So that's another really good resource to leverage. There's also like the Alzheimer's Association, they may have some resources that can help caregivers and those kind of trying to obtain assistance.
So we actually do have some of that contact information that will be placed in the chat wherever you are. The Alzheimer's Association is alz.org. Is that correct?
Yes.
Okay. And then there's also a national one, if I'm not mistaken. So it's two organizations. And I think we also have phone numbers listed in case you don't have web access and you can still get through. So we do have 800 numbers included as well that should be placed in chat. So thank you for talking about that. I think that I'd like to kind of go back to two different things that you had mentioned. One about respite. Could you just define what that means, please?
Yeah.
Sure. So respite is a break for caregiving, and that really looks different for every caregiver. For some, it may be going on vacation. For some, it actually, honestly, it may be getting rest, like literally just sleeping. For some, it may be picking back up some hobbies that because of caregiving they weren't able to do. So it looks different, but essentially the definition of respite is a break from caregiving.
Okay. Thank you for that. And then the other question that I had was to kind of piggyback on Dr. Melissa's question with the Medicaid. What is that? What does spending down mean? Because we hear about that term a lot, but I don't know how it applies in this case.
Sure.
Could you shed some light? Thank you.
Yeah, so spend down is it's a Medicaid for individuals who are over income for, as Dr. Melissa kind of termed, your poverty line or your Medicaid limit. And within the spend down, you would contact your state Medicaid agency, because that looks different for each state, because each state going back kind of defines what their spend down is. Once you contact them and they do, I don't want to say a means test, but they look at your income and they tell you how much you're over the spend down amount. They will tell you the period and the amount of money that you need to spend down to get to the Medicaid limit and what services would be contributed to that. So for DC, when I used to work with caregivers, if you pay for a burial lot, if you had high medical bills, you could use that. If you had in-home support, mostly by agency. I've seen a few where they would do, like if you're using a family caregiver and paying them and have that connection. But there are a series of services and that they contribute to, that they look at when looking at your spend down amount and what they take for it.
Okay.
So in other words, if you have too many assets or you make too much money, there's certain things that you could spend that money on to kind of get rid of it so that you would then qualify for Medicaid, and then Medicaid would take over paying for those things.
Yes.
Yeah.
Yes.
Okay.
Thank you, Dr. Melissa. That's a great way to put it. And then also getting connected is a good way, because they'll let you know what your amount is per the time, and how to submit that and how to calculate it, etc.
Yeah.
So thank you so much for breaking that down.
Yeah.
So I think we're really getting to
there's-
the heart of some of these questions, because it's just so overwhelming, first of all, to receive this type of diagnosis. It's really difficult to figure out where to begin. And I've heard talk about Medicaid, I've heard talk about managed care, but I haven't heard anything about Medicare. So where does that fall?
So Medicare does supply a limited amount of services, and that's depending if you're getting occupational or physical therapy. A little bit later, I was going to talk about elder care, and there's a thing called the state health insurance program, where it kind of goes through what your Medicare benefits are, what that looks like in open enrollment, and that would be a great resource to give them a call to see what you need to do to get connected to in-home support and any of those services that your loved one may be eligible for.
And Medicare for everybody is, different from Medicaid in that it kicks in if you have a disability, and you've been certified as having a disability, or you reach the age of 65 and older, you automatically get Medicare as your insurance.
Yes.
But it doesn't cover if you have to go into a nursing home, but it does cover visits to the doctor, or if you have to have rehab, or if you have to be in a hospital, whereas Medicaid would cover if you had to go into a nursing home. So that's an important distinction.
Yes.
Definitely.
I
And then
wanted
there's
to,
sorry to,
yeah. Oh no, go ahead.
and then there's also state plan Medicaid. And then there's like, I don't want to say long-term care, but there's different levels and depends on, like, back to your level of care, especially when you mentioned going into a nursing home. Long-term Medicaid is, for lack of a better word, is what you would say when someone's kind of going into nursing home. That's regular than community Medicaid, and there's certain services and supports that are covered under each one.
Great. Thank you for that distinction. I really wanted to get to this question before we get back to Dr. Agarwal. What decisions and therefore discussions should be happening in advance while the person living with Alzheimer's disease can still make decisions for themselves? What should you be talking about as a family?
Sure, that's another great question. Some of the beginning conversations should be how would they like and where would they like to receive care? Their 5 wishes, which is a really good online tool for those who do have web access, that kind of gives you talking about like advanced care planning. Then there's also talking about getting a PO, a power of attorney, whether medical or financial. Also, what type of insurance they have, because sometimes people don't realize, they think they may just have Medicare, but then they have a secondary insurance, or depending who they retired from, they may have all these different insurances. And then Dr. Mel, you also talked about having long-term care insurance. Some people may have forgotten they actually, have that insurance, because they may have done it when they were in their 20s, 30s and paid into it. So that's another really quick question. And any other benefits that they may have, if they have like a Roth IRA or anything at that stage in which they could, take the money out to pay for their care. I would say also a living will and advanced directives. All of those are really good. I know it's a list of things, but those are all really good things to kind of begin to discuss with your family at the beginning stages.
Mm-hmm. And an advanced directive basically says what kind of care and how much care would you want in this particular instance if you stopped breathing, or if your heart stopped, or if you couldn't eat anymore. What kinds of interventions would you want? And those are great conversations to have, which are sometimes very difficult to have, but then when the instance actually happens, you really wish that you knew what the person wanted. So it's better to have it earlier rather than later. Karen, I'm sorry, you were going to say something.
That's quite all right. You made an excellent point, and again, I'm thinking about the level of overwhelm that some people might be experiencing. We can talk about this sort of thing in a calm space, but is there a place where somebody could just make a phone call and be connected with someone who can help navigate these various pathways? And I'm using that word deliberately, but is it a social worker? Is it the Department of Aging? Is it a social worker in the clinical setting? Is it someone in the neurologist's office? Where would someone, a caregiver, a family member, turn to?
So all those places, that is an amazing question. So all those places are kind of entryways into getting information for care. DC Department of Aging is, of course, the District of Columbia, but there's also the Elder Locator, which is really good. It's on the Administration for Community Living's website, and I believe I provided that link as well. You can type your zip code in, or your state, and your area in aging, which they would be able to do an intake and get you connected to referrals and resources. There's also the National Action Caregiver Network. That's a really good one to get started on. Now I'm a caregiver. What do I put in my toolbox? How do I just not only get connected to services, but really how do I leverage these services and understand how to use them? One good thing when I was talking to caregivers, sometimes they didn't understand how to use respite or how to use the team around them to really leverage the support that they could, even if it was like, hey, I can't do physical care, but I may be able to drop off meals. So those are I know you didn't ask that, but I'm kind of jumping ahead. But
It's fine because I was about to go there. So we
okay.
are in sync because
Yeah.
we're by team. That's what it is.
Okay. Yes.
Please
So yeah,
continue.
so I was so sorry, just contacting Elder Locator, and then
Mhm.
also once getting connected as a social worker, if you are in a hospital setting, asking the hospital social workers, sometimes doctor offices, they have case managers or social workers or a care manager. And the really good thing now, even with insurances, they also have care managers and case managers that can kind of help guide the person in need of services.
Those are
To answer.
excellent. Yeah, thank you so
Mhm.
much. I can't believe it's almost time to bring in audience questions. So I want to bring back Wayne and Dr. Agarwal to the conversation and take a break, see if there are any audience questions. Wayne, what do you have for us so far?
There are. Let's start at the top of the audience questions, and these have come in fast and furious. We have a question from Rhoda Lawrence. Rhoda asks, when does the absent-minded indicate something more serious is at play? When does being absent-minded indicate something more serious that is at play? At what point should you be tested?
Okay, a great question. Great question. To me, when I hear absent-minded and it's interfering with your ability to get things done and carry on your business, and all of a sudden now you have bills that are not paid, you have late fees, you've missed doctor appointments, that's something to talk about, okay? And that is something that is when you go in and say, I need to be tested, I'm not sure about my memory, and that's when you start talking. It's when it starts to interfere with things. And also people may tell you, wait a minute, what happened? You were so on this before. You're not on this anymore.
Wow.
Oh, all right. Second question comes from DJ Lance Reynolds. Let's say a loved one has just been diagnosed with stage 1 Alzheimer's. What would be the next steps? What would be the 3 best first steps?
Okay, so that's a good one too. So the diagnosis now has been made. You heard Linda, and I was off screen, but I was nodding my head to everything she was saying. Everything she was saying. Now is the time to first look around and think about your team. Who's on your team now? And we all look to family, of course. And I always tell my people, we love our family, but family may not be your team. Okay? They may not be your team.
Amen.
And that means you need
Agreed.
to really, and I say this to people, listen, no disrespect. It's just that there are so many other resources that your family may not know, that a social worker knows, an organization knows, and you need to start putting your team together who may be called up to give support at a certain time. Okay? And I say this even before we talk about medication, because as a physician, I'm thinking about that. What medicine should we start? I'm looking for the team. And sometimes my people come in with a daughter. Most of the time it's a daughter. Sometimes they come in alone, and I ask, who's going to be there to support you taking these meds or bringing you to a visit or getting a follow-up? And so I'm thinking about a team. So that's the thing. You want to get your team together. And here's the other thing. I have to say this, Dr. Mel, to everybody. You cannot bring people across the finish line. Okay? Either they're on or they're off. And right now, it's a moment in time. Right now, they're not able to help. Doesn't mean they're gone. It's just that right now they are not on the team. Okay.
Right.
And you may find them later, but right now they're not. And stop wasting your time trying to put everybody together. And that goes to all the family members who are trying to round up their siblings to get together, and it's not working. So once we have the team, then we start talking medicines. What would be the best medicine given the profile of your loved one, the medical conditions that mother, father, sister has. What are the side effects of the drugs related to their medical conditions? And the one big thing that I always talk about is heart conditions. If somebody has heart issues, they're on blood thinners, medicines where they're an AFib, or they may be having an ongoing cancer, or we think about what medicines to try. And sometimes we will not suggest an aggressive medicine because we're worried about the underlying medical condition. Okay. And then the last thing is, you know, again, going back to what Linda said about social work, how is the environment? What is the environment like now? Is this environment supportive of the person? Nobody wants to move out of their house. I have yet to meet anyone who wants to get out. They all want to stay. But I always say, but is your environment supporting you to live your best life?
Exactly.
And if it's not, how can we make that change? And if we can't, what should we be thinking of? And that's where the discussion goes. And that's where the social workers can really step in and say, here are some options.
That is so excellent. And if I could just add about your team, think not necessarily the people that you, the caregiver, knows. Think about the community of that person. Who are their friends? Who loves them? Who's in their church? Who's in their civic organization? Think broadly, because you never know where your help is going to come from.
Exactly.
Yeah.
And I might also add that culturally, because I always have to bring in that aspect, we tend to look at the children, and in particular, the elder children or the female children, culturally speaking. And we, to Dr. Mel's point, need to think beyond that. And to Dr. Agarwal's point, even if there's a battery of siblings, maybe they cannot all be helpful in that way, but maybe some of them can contribute funds or manage something or come in as a pinch hitter, as Linda was talking about, as a respite and relief. That's so important.
It's so important.
It's like building a baseball team, isn't it?
Exactly. Right. Designated hitter comes up. The pitcher is doing the job. Everybody's got a job. Nobody can do it all.
Right.
And nobody should do it all. Okay.
Absolutely not.
Nobody should be doing this all, because you get burnout and then you get resentment. And once we get resentment, then we have big problems.
So we're gonna cut you off there, because we have a couple more questions. Joseph Parker asks, what services are available for those who desire assisted suicide?
Wow.
That's a good question.
That's a Dr. Agarwal question.
That's a tough one. I can tell you, I really don't know what's the latest right now. You know, we do assess, I can tell you, suicidality. We do assess that. I think Dr. Mel in the ED, I'm sure you're doing that too. Is the person actively suicidal? And there are protocols for that where we can even get a person admitted. Okay. But what you're asking is very different. You're asking assisted suicide, like based on a diagnosis. I don't know about services, and I don't know which physicians honestly would be talking to a person about this. I'm thinking hospice is probably going to know about this a little bit more. My hospice colleagues would be palliative care people, would be the ones that would talk about what you can and can't do. And again, to your listener, Wayne, every state is different. Every state is different in this aspect. So what you may hear going down in California is not the same going down in Oregon or going down in Illinois. So I would suggest, if this is something really thought about, figure out what is the state mandates on this.
And there is one organization called Compassion and Choices. You could Google it, that speaks to that very issue. And I also want to interject too around depression, having your loved one evaluated and potentially treated for depression, because that may alleviate, it won't necessarily stop, but it might alleviate some of the symptoms that individual has.
Okay. Have a few more questions. One, Amma Joseph says, just now join. Can you stop Alzheimer's before it occurs?
No, that's what we're working on it. We are working on it right now. And I'm so glad that that question came up, because now we're using the term preventing Alzheimer's. How do you like that? Instead of waiting for it to happen and get active, right? Prevention.
Fantastic.
And so the drugs now that are being looked at are trying to get it before it even starts, clearing that amyloid before you even outwardly show signs. So we're on it. We're working on it.
Fantastic.
And I think there are lifestyle things too that you can do. The same things that help your heart health, help your brain health.
Absolutely.
So, yeah. So eating your leafy green vegetables, decreasing your processed food. So focused on nutrition, getting enough sleep every night, exercise, walking, exactly. Staying well hydrated and managing the stressors in your life, having some sort of ritual on a daily basis to manage your reaction to the things that stress you out, quote unquote, stress you out.
So we have another question, a statement and a question from Michelle Walker Scales. She says, oftentimes nursing homes are the solution, but nursing homes can be a real challenge in terms of the lack of good care. What is the best way to work with nursing homes to ensure our loved ones are taken care of in the best ways?
That's a whole show, but I'll leave that to if there's a short answer for that either Linda or Dr. Agarwal have.
No, Linda, you got this one about working with nursing homes. No, seriously, because I'm sure you know tactics.
Yes, I would say having the staff understand your loved one. So if you can write out things about your loved one that they should know about, I would be saying be present. Also, before having your loved one enter that nursing home, do some research on them. Medicare.gov actually rates nursing homes, so that's a good way. There's also caregiver news where they have a checklist of things to look for in nursing homes and other places that in where you're trying to place your loved one. So those are just some kind of those things that I would say to look at and to be mindful of when putting your loved one in a nursing home.
And I'm sorry, did you say caregiver news? That's a separate web page?
Yes.
Okay. All right. Thank you.
And,
yes.
And as you all know, the book, Excuse Me, Doctor, that this show is based on, has a checklist for how to choose a long-term care facility and a rehab facility, all the things that you should look for.
Where can they get that, Dr. Mill?
They could get that at drmelissaclark.com. But I have to say that it really should be a next show that we do at some point. Because it's a very rich topic, and I think Linda, you did a great job of taking a short time to answer a really big question.
We've got the purple. We can do it, I think.
Yeah.
Okay. So question, this is a lightning round. So all the answers have to be really quick. Renee writes, what would be the treatment recommendations for those who have comorbid conditions alongside an Alzheimer's diagnosis? What is the prevalence of comorbidities with this diagnosis?
Okay, I'm going to start it off. Prevalence of comorbid conditions are very high with Alzheimer's disease. Cardiovascular conditions is probably the top ranking that we're seeing right now. People with heart disease or have had a stroke have Alzheimer's disease. So when you think about treatment, the newer drugs that are coming out, the new one that just we're talking about that happened last week, there is a very strong possibility of bleeding in the brain if you are taking a blood thinner and have a cardiac condition and taking a blood thinner. So that would not be the top line choice right now for someone to get that drug. We would go to the drugs that are on the market and start one of those drugs, which we know the profile is a little bit better with. So that would be my thought.
Okay. Thank you, Renee. One last question from Marv West. Please comment on having insurance before getting diagnosis.
And I think he specifically means long-term care insurance. Linda, I don't know if you want to take that one.
Sure, I can take a stab at it. It's definitely important having long-term care insurance, but there are a couple of things that kind of go into when getting a policy. Your current health, the age you're getting it, those are kind of factors into like getting long-term insurance. I would say if that's not an option for you, looking at getting a secondary insurance, AARP and other places have some secondary insurances that you can also look at that would be really good when looking at insurance coverage for care.
And that's time.
Great. All right. Well, again, you all have been incredible in terms of the amount and depth and kinds of information that you've passed on about Alzheimer's disease. We really appreciate you, Dr. Neelam Agarwal, Linda Rosari. Really appreciate all the information you've shared with us tonight. Of course, thank you, Karen Parker, for being here once again with us this week. And of course, to Wayne Bruce, producer extraordinaire, thanks again. And to our Be Health Empowered family. Y'all came with the questions tonight. So we really appreciate you. Remember to check the chat for a lot of the resources that we talked about. And before I go, of course, I have to remind you that there's that special research study that's still going on at Howard University at RCMI. Now, you know what it is. It's the COVID Resilience Research Study. All you have to do is fill out 2 surveys and you can receive $100 in compensation. If you have any interest whatsoever, just reach out to Dana Harvey at her email, which is danaharveyresearch@gmail.com. Dana, D-A-N-A, Harvey, Harvey, research@gmail.com. Well, that's it for us at Excuse Me Doctor this week. Thank you so much for joining. And remember, until we see you again, be wise, be well, and be health empowered.
I guess I should thank the Robinsons. They invited me. They still don't know. I hooked up with Dave 3 days ago. He'll start coughing tomorrow. And I bet in 10 days he'll be on a ventilator. Now, his wife, she's not vaccinated because she thinks it'll prevent her from being pregnant. But what they don't know is that I can decrease sperm count. Sorry, Dave. Good luck with that.